The next speaker has special interest for non-vascular interventions. He also has gained much of experience in taking difficult biopsies. He has expertise in doing tips. Besides complex procedures, he is also helping patients of heel pain and ankle pain to get rid of it. I would like to welcome Dr. Rozil Gandhi once again on the dais.
Thank you again for the second part of the introduction. Uh, just like Russia is pounding Ukraine with the bombs and missiles and drones, we are pounding our viewers with embolization, and embolization. So, many embolization, as I mentioned, we treat tumors, we treat bleeders, we treat various pathologies, vascular malformations, varicose veins, and now embolization for inflammation. Uh, our previous speaker mentioned 90 to 95% of the achilis tendinopathy can be treated with physiotherapy. So we are here for the rest 5%. This is a novel intervention that could transform clinical care and shift the current paradigm from treating non-malignant musculoskeletal pain. So this is called TAE or TAME because we are embolizing the microvasculature. We are embolizing the capillaries. We are not closing the parent vessel with coils. We are just embolizing the hypervascularity or the moya blood vessels. Chronic musculoskeletal pain is a major public health burden. And identifying a safe, effective, and durable intervention. NSAIDs help until you take NSAIDs. Physiotherapy also helps until the patient continues doing the same physiotherapeutic management at home or under a trained physiotherapist. But what afterwards? Embolization gives a durable treatment for a long term because effective pain control helps in major improvement in quality of life and improved mobility. As I mentioned, the first part is NSAIDs. They are relatively inexpensive and non-addictive. They are the current mainstay now as a first choice. But there are issues with that also. They cause acidity and the gastric issues. So we have to give a pantoprazole and other like-minded drugs for that. There are safer alternatives also, but opioids can have risk of habituation and addiction. For knee osteoarthritis, there are repeated intra-articular corticosteroid injections. Also for steroid injections in the tendon have been mentioned to be useful. But they cause thinning of the tendon or thinning of cartilage. NSAIDs also interfere with the healing process. So we come up with embolization. Because osteoarthritis and tendinopathy, they are not just wear and tear disease. They are result of chronic inflammation. There is proliferation of abnormal vessels and it increased migration of immunoeffector cells to that area, which leads to the cartilage or the tendon destruction and perpetuation of local inflammation. So embolization targets the hypervascular synovium physically and medically debulking the pathogenic synovium by causing its necrosis. Neurogenesis can be upregulated in parallel with angiogenesis, which is contributing to the pain. So we see the angiogenesis, the moya blood vessel or the hypervascularity on angiography. But what we not see is the neurogenesis. By angiogenesis, there is neurogenesis also, and neurogenesis causes pain. So by embolizing by treating the angiogenesis, we are treating neurogenesis also. So it is an effective and reasonable surgical alternative for chronic asymptomatic tendinopathy and enthesopathy. Follow-up MRI after embolization, it shows resolution of tendinosis. So we have an objective report also that embolization helps. This is the ankle vascularity surrounding the ankle supplied by the posterior tibial, anterior tibial. Achilles tendon is generally supplied by the branch of posterior tibial artery. Middle-aged female, pain in posterior ankle since 2 years, hampering day-to-day activities, not relieved with conventional conservative management. We take a femoral puncture, as I mentioned earlier, with a 4 French sheath that is 1.3 millimeter in diameter under local anesthesia. So there is no incision, no suture. So it is a pinhole technique. So this is a angiography image of posterior tibial artery, the artery supplying to the posterior part of the ankle. And this is the hypervascularity, the black thing. Rest of the vessels, rest of the areas, there is no hypervascularity, but hypervascularity matches with the patient's area of tenderness. So we go very selectively in the branch that is supplying the hypervascularity and we embolize it. So super selective cannulation of the feeding artery is done. This is post embolization. Rest of the arteries are patent, they are open. So there is no chance of ischemia or necrosis. And you can't see a hypervascular or moya area, inflamed area here. So we have treated the hypervascularity. We immobilize the patient for 4 to 6 hours. Generally, patients have complete pain relief from the next day or more than 70% pain relief, and within 6 weeks they get a complete response. Routine activities are allowed from the next day. So we propose to keep the embolization as a treatment option after failed conservative management and before surgical trial for Achilles tendinopathy also. Our experience for Achilles tendinopathy, just Achilles tendinopathy, is more than 10 patients with complete response in all. But embolization for inflammation, for knee pain, for frozen shoulder, total we have crossed more than 500 joints. Recent article of March 2022 by American College of Rheumatology, embolization for chronic musculoskeletal pain. They have done a systematic review and it is effective for chronic refractory pain. So this is the content of that article. They have used for multiple sites: knee, elbow, shoulder, frozen shoulder and trapezitis also. Thank you.